I mean, when I say above it, like we're literally, when we're looking at CTs, we're marking our access just, centimeter above, if that. All right, and that's, you're exposing the carotid is all you're doing. It's a small window just so you can visualize it. Put an 8-French sheath in the carotid, and we provide everything specific to that. We provide our micropuncture kit, we provide the wire that's included in this kit here, and the sheaths. So again, an 8-French sheath in the carotid, we put an 8-French sheath in the femoral vein, and then we connect it with this large bore tubing. And this large bore tubing has a filter in it, and this is basically an out of the body shunt. So when we clamp the carotid, we're gonna provide flow reversal because we have higher arterial pressures than we do venous pressures. And that's why we have anesthesia here, because we're gonna rely upon anesthesia to keep pressures in the 140s, 160s systolic. And that pressure provides flow reversal. So when we clamp this carotid, you'll see everything will flow backwards. If I were to hook this sheath up, this arterial sheath up to an arterial sheath in the femoral artery, so like say we got femoral arterial access, which can happen, we won't get any flow through it, and it'll just stop. You'll notice it. But if you're hooked to venous, it'll flow nicely. And it hums. I mean, it's essentially the same pressure as the patient's pressures. But we're doing this so that while we're ballooning and stenting the carotid, we're protected the entire time. Nothing crosses the lesion before we're protected, before we're on flow reversal, so to speak. Average case time is 45 minutes for Dr. Reiser, 60 in the nation. And average clamp times are 10 or less. So we're not on flow reversal very long. We work these cases up via CT imaging, and we're pretty thorough about depths, access lengths. The one we're doing Wednesday, I sized it myself. It's great. I think we had 6 or 7 centimeters runway length. We had probably a depth of about 3.5. Everything else measured out nicely. So access, in my opinion, is the hardest part of this. Truthfully, is getting that sheath in the carotid. That's the hardest part. Some people like to come in real steep. Some people don't have great counter traction on their carotids. Dr. Reiser uses umbilical tape, which I think is probably the best. We don't recommend it, but, anything differently, but some people like to use vessel loops. And when they're putting the sheath in, the carotid already kind of moves with the sheath, right? Whereas as an umbilical tape, right, you get that 1-to-1 counter traction. Yes, it's nice. Sheath goes right in. But that's it. I mean, that's the hardest part, in my opinion. And you'll hear us sometimes, I don't know, will we have a first assist with us on every case or no? Just a surgical tech? 2 surgical techs? Please.
Be nice.
Possibly.
Yeah, that's ideal, because what you'll have is when he's doing his cut down, and of course the arterial sheath insertion, someone up top to help him with that, while someone else is on the back table, prepping the stent, handing off wires. That's the hardest part. If you had one person, is just be in 2 places at the same time. But everything usually is prepped and ready before the case starts. Dr. Reiser is really good about that. We try to minimize how many things we're trying to hand off during the procedure, just because, again, time is of the essence, especially when we're clamped. We'd like everything to be on the table. So steps, I'll go through those pretty specifically. Again, cut down. Usually Dr. Reiser does his femoral venous access first. Kind of gets that out of the way, unless he has ultrasound issues, and then he waits on ultrasound. But usually he's femoral venous access, and then he does his cut down. And then once those things are ready, we'll basically go to put the sheath in. C-arm will come in, we'll do our micropuncture access, we'll put the sheath in over an 035 J-wire, which we provide. Once the sheath's in place, he'll basically connect to the tubing. Once all that's done, we'll shoot a working view, which is basically contrast angio. We'll mark everything on the screen. We agree on where we're going to deploy the stent and balloon, and then you'll hear us do a TCAR timeout. We'll say, hey, we've got pressures in the 160s, heart rate's good, ACT is above 250, which Dr. Reiser does a good job of trying to do the ACT, heparinize and do the ACT early, so we're not waiting on it when we're ready to clamp. But once we've approved everything as far as products on the table, all the requirements are met, we're then going to clamp. He's going to go straight up with the wire. He's going to go up with the balloon. We're going to balloon. We're up and down the balloon. I mean, rarely are we up, any longer than we need to be. And then once the balloon's out, we're up with the stent. And then maybe 30% of the cases will post-dilate. Usually it's calcific, and I'll have already opened a balloon for that post-dilation because we know all of those need to be post-dilated. Soft lesions and whatnot usually don't have to post-dilate. And then once you've deployed the stent, everything is good. He's pulling wire, moving C-arm out. and then someone can hold pressure, pull sheath, and hold pressure here, and then he's closing the pocket, and then we're done. That's it. It's easy.
But we're done, but we're not done. So explain the part about the neuro check.
So once he's closed the pocket, we're gonna wake the patient up. A lot of times we just move him over to the bed, extubate the patient, wake him up, and we want to do a neuro assessment. We'd like them to squeeze contralateral hand. We'd like them to wiggle their feet and stick out their tongue. And then when we leave the table open and sterile up until that point, just in case we need to re-intervene. But again, not to jinx myself, but we've done probably 2,000 in this area, and we've not ever gone straight back in. So I think it's a precaution we've always taken, just because it's possible. And a lot of times what you might run into would be an instant restenosis that maybe the patient has a heparin allergy or something, and they've got quick rethrombosis of the stent, which is unlikely, or maybe you have a flap at the access site, which you didn't notice under angio. But usually we take a lot of serial angios post-op. We'll take an LAO 30 and RAO 30 just to look at it from two different views. And once we all agree that we're good, we're pulling wire and coming off clamp, and we're done. So that's it. Any specific questions I can answer? Most of the items are just flush. We're flushing micropuncture kits, we're flushing the stent, and we're flushing the balloon. That's it. Nothing crazy.
As far as instruments for the back table, did you go over that?
I always just say it's a vascular tray. You want 90 degree, right angles. You want hemostats, DeBakey's. You want a couple different types of clamps. Profunda and maybe a DeBakey clamp, umbilical tape. Again, additional stuff that we don't usually have open is an inflation device for the balloon. We do several 2-0 silks, and that's just so you can suture the sheaths in place, right? Just stitch in place, that way it doesn't move on you. Usually we'll carry it, we'll bring a couple other extra wires in just in case, 99% of these cases are 014 wires doing the job, but occasionally you might have some tortuosity or something weird. We just got acquired by Ball Scientifics, and my hope is that maybe I can start, carrying some of their wires and balloons as sort of add-ons in case I needed them. That'd be helpful.
Chris, what tray do you think?
It's a small artery tray.
Okay. I'm just gonna make sure the card is.
Yeah,
Which that tray was Riser's tray before he left, and so
cool.
most of the stuff is still the same as.
So, and you're still going to get a TCAR cart for us, correctly?
It's here.
Oh, great.
It's here ready. Yep.
Perfect.
Yeah, TCAR card is upstairs. At least last time I saw it, it was in the ortho room. I put it together maybe a couple weeks ago.
Okay, perfect.
It's got everything on it. The only thing, at the time, I think the micropuncture kits had all gone to the cath lab maybe. But I think they had everything else. I just needed to go. Actually, today I'll do that. I'll put together, make sure we have the extra micropuncture kits for the venous access, and then just like a Benson wire or just a J wire for that venous access, because we don't provide that. But I'll make sure we got those and the inflation devices on there.
Arms tucked back like a
shoulder roll. And Dr. Reiser's pretty good with that. I say this so handy, his first assist used to help out with that.
Mm-hmm.
We'll get Dr. Reiser involved, make sure he's positioning right, but you're just wanting to extend as much as you can. Yeah,
so
it helps.
Shoulder roll and like a little
shoulder
head.
roll, make sure arms are down, pulling down if you need to, because sometimes they're shrugged. It's a simple, again, we usually just roll up like a blanket.
Mm-hmm. And we can do the A-line on either side if we closest to the machine.
As long as they're not some
okay.
kind of a subclavian
Yeah,
issue.
yeah.
Okay. Which we usually look at too, we try
Okay.
to. If I have imaging that shows me.
And you said take
That being
the tube
said,
away
CR
from
needs
the
to come in
bottom.
up on the head of the table.
Okay.
I had one scenario at Sonova where the bed was backwards and it's CR underneath. So I'm pretty careful
So
about that.
like from the head, top
Yeah,
of
you
the
just
head, or
want the
from
open
side?
part of the bed, we're gonna come straight in. Usually, and it's the same side, whether Dr. Reiser's working on the left or right, C-arm's usually coming in on the left side of the patient. He may come over and do the cut down if we're doing the left. If it's a big patient, he may stand on the left and just do the cut down, but all of his ballooning and stenting, he'll come stand on the right.
Is it okay to use a standard table for this if we don't have radio translucent available?
Usually, yes.
Just move the base of it as far down as
Yes.
we can? Okay.
Yep. As long as we can see, I mean, occasionally he'll come and look through here just to be sure he's got venous access. For some reason, he's had trouble there. But 90% of the time, you just want to be here up.
Great.
And we need to be able to swing pretty steep. LEO, REO. I mean, nothing usually more than maybe 35, but.
So move the bed back up into the, sounds like we'll need to move the bed a little bit into the center. Okay.
I don't know, what rooms are we going to be working in, do you know?
It
Just
could,
depends.
yeah, it just depends.
Okay. And we're here for every case. And again, I just left Fort Sanders and we've done 300 over there, and I still stand back there at the back table and walk them through prep from time to time. I mean, believe it or not, it's crazy. Just, and there's a series of stopcocks, so sometimes that can throw people off. They're like, crap, it's not holding, it's not flushing right or whatever. Again, we're here to help. That's what we're here to do. And anesthesia, I'll apologize ahead of time. I feel like I get the most pushback from anesthesia. I'm not trying to pretend like I'm practicing medicine, but I will say this. The cases I've had that were the worst were, the cases where I was recommend something and they wouldn't do it. They wouldn't
Like
stay.
pressures?
Yeah, and that's usually what it is. I might say 160 systolic 1,000 times, and for some reason we're at 100 the whole case. And I get it. It's one thing if you're working on it, it's another if they're not, and usually that's the case. Usually it's I'm doing what I want to do kind of thing. Yeah. So, and the glyco, I get a lot of pushback on the Robenol. We actually had an anesthesia speaker that worked for us that went around and spoke for us and kind of reiterated that, like, all day long, pre-treat. Yeah. I mean, again, I've had 3 where we chose not to during the case. And I get it, the patient's rates were like 110s, and they didn't want to elevate it any further, but those are the patients that as soon as we ballooned them, we were asystolic, and then we're chasing both heart rate and pressures the rest of the case. And it just speeds up the case, and I feel like you may not post-dilate if you needed to, you may not spend as much time looking at the stent as you might need to be sure that everything's fine. And that just, I think, causes a little undue stress. But knock on wood, it's a great case. I mean, it's fun. They're all pretty effortless. Again, post-op, nothing below 100. We usually say nothing 20% over baseline. So whatever their baseline pressures are, but again, a lot of these patients are 180s. So I usually hear the physician say 110 to 160.
And just the patient condition will decide where they're going post-op after
usually.
PACU. Okay.
Hey. Oh yeah, look at you. Look what you got. It's like gold.
Oh, look, cartridge is full.
Thank you.
Thanks, Bob.
That's usually our biggest
Expected
hold up
any less.
is an ACT machine.
Yeah, we know.
Yeah.
Do y'all have any other
Yeah.
questions, guys?
I know, I hope I haven't used
As
one.
far
lately.
as like losing pressure, we're gonna throw.
Hold on, we got a question.
It's
We
a
got a
venous
question. What was your
sheath,
question?
so
I'm
5
sorry.
minutes. I mean, it doesn't take a lot,
Yeah.
and they're gonna give protamine as well. So usually it's not bad. I mean,
David, what was your question? I'm sorry.
I was just asking about holding pressure on the venous side of it when we're finished.
and most do it during the procedure, like while he's closing, someone's holding pressure, and then that way when you want to put the patient on the bed, it's just move them over, we're done.
Bring it back and keep it. No, you didn't need to do
Good question.
cardio. No.
But
Any other
again,
questions?
those books are great. I mean, there's tons of QR codes, but again, we're here every case. So we're gonna walk you through prepping stents, prepping balloons, and all that stuff's on the table before you start the case. Before the patient usually rolls in, truthfully.
So if you wanted to open one package, you could.